Let me kind of start by telling you how STI evolved and what it is. I started about 2 years ago working as a nephrology social worker in Oceanside, California. And that is how I developed Symptom Targeted Intervention. And what happened is after a couple months of starting my work there, I noticed that quite a few of my patients had symptoms of depression. So I would do what we were supposed to do, which is refer them for outpatient mental health treatment. And much to my surprise, none of the patients actually went for outpatient mental health. So basically the patients didn't go, but they still had their symptoms of depression. So then I thought, I wonder if I work with a nephrologist, maybe they'll, prescribe antidepressants. So that was sort of my next approach. And I would sort of try to get the nephrologist to, where appropriate, prescribe the antidepressants. But again, a lot of the patients really didn't want to take yet another pill. And furthermore, it wasn't always appropriate because a lot of the patients had more maybe dysthymia or an adjustment disorder. And so sometimes I would find myself getting caught up in trying to diagnose what they had. Is this a depression? Is this an adjustment disorder? Is this dysthymia? And I think this probably sounds familiar to all of you. So I was sort of left holding the bag. Like, what am I supposed to do? Because on the treatment plans, like now we're doing our treatment plans and I'd have depression or a depressed mood and I wouldn't know what to do in terms of intervention. So that's kind of where this started. So what I thought is, let's go back to basics. Let me go do some research. So I went to my alma mater, UCSD, and I did a little research. And there are quite a few articles actually on depression in dialysis patients. And what I found was actually pretty shocking, and that is that around the ballpark of 25% of dialysis patients have symptoms of depression. And they're more likely to actually end up in the hospital and die as a result of their depression. They're also more likely to have peritonitis, to shorten their treatments, to be non-compliant with recommendations. And all of this was really compelling and actually really surprising to me. So in a way, it kind of made me more committed to trying to figure out how to help these patients. So then I did another search to find out what other practitioners and social workers were doing to help these patients with their depression. And there were only a couple articles basically on how to treat depression in the unit. And the articles were doing CBT, cognitive behavioral therapy. But when I went through these articles, basically they were using cognitive behavioral therapy with 8 to 10 sessions, and each session was 50 minutes long. And you guys are probably having the same reaction that I had when I read that, which is there's no way we all have so many patients. I think at the time I had like 140 patients in 2 different clinics. So that really wasn't feasible for me to do, 50-minute sessions. But nonetheless, my curiosity was piqued and I was really curious, well, what are these people doing exactly in these CBT sessions? And of course, the articles don't really tell you what they're doing. They just say they're doing CBT. So then I started doing other research. I got a bunch of books on CBT, and with a couple of my colleagues, I went to a course on CBT, cognitive behavioral therapy with a cognitive therapist here in San Diego. And I started learning some really interesting interventions and techniques. And so what I tried to do then is kind of modify them to our setting. And after reading some books and going to the training, I had these sort of techniques and these tools, and I thought, oh great, I'm going to go out and I'm going to sort of work with these patients and do some of these things. And actually, this is the interesting part. This is how the actual STI happens. So I go out to the patients, I go out to the floor, really excited and with all my new techniques, and I'm sitting down with the patient and I kind of start getting into it, and then I hear my name being called over the loudspeaker that I have a telephone call. Then the patient's phone rings. Then the nurse comes and grabs me for something. Then there's a crisis in the other room. So basically it was constant interruption, and I found that I really didn't have much time with them. It would be like 10-15-minute increments that I had with them. And so finally, I remember just sort of thinking to myself, let's just cut to the chase. What is bothering this patient the most? And so what I started doing was just sort of focusing the session on the actual symptom that was bothering them the most. And it was really good for me, and it was good for the patient because it focused our time together. So rather than, and we all know this, that depression is really sort of a collection of symptoms, and not every depressed patient looks the same. I would sort of, collaborating with the patient, find out the most salient or troublesome symptom of their depression, and I would channel my energies and use my new techniques and focus on that particular symptom. And then what would happen, and I would give them homework, and I would do a little psychoed, because all of these, interventions are heavy on psychoeducation and homework. And so I'd sort of make a suggestion, they'd take it home, they'd come back, and we'd try multiple interventions before the symptom resolved. And then this is the interesting part. The symptom would resolve, not only would the symptom resolve, but their other symptoms would sort of clear up as well. And that was the surprising thing for me, because I thought we'd have to deal with this symptom and then maybe deal with another symptom, but the other symptoms kind of resolved. And I think what was happening was that the patients were learning skills, they were feeling more hopeful, and it was like a domino effect. And I realized going back, I think the theoretical framework for STI is systems theory. And you guys probably all remember back in graduate school maybe learning about like Bowenian family therapy, which is a family is a system, and if one member of the family changes, the other family members are forced to change. So if the analogy here is that in depression you have different symptoms in a constellation, you change one symptom and the whole constellation changes. So I think that's why it was working, and it was just such a cool experience to see.